Hello and warm welcome to ENT student for discussion on neuroectodermal tumors. Yes, you can start.
My topic is neuroectodermal tumors. Neuroectodermal tumors can be divided into two groups. The first group shows evidence of epithelial differentiation, which are carcinoid tumors of the larynx. And the second group is a diverse group of tumors that shows non-epithelial differentiation.
Just a moment, please. I'll brief up and then you can start. Okay. So generally, this you get down, please. I'll complete this. I'll complete the slide and then you can go to the next slide. That's what I say. Okay.
Okay, sir.
Just a moment.
Okay, sir.
So these neuroectodermal tumors.
Yes, sir.
So especially they are divided into two groups. Number one, first point. So first group, they have got epithelium as a differentiation. Number one, example like carcinoids, and second group, they are a diverse group, that is non-epithelial. So you can be calling it as epithelial and non-epithelial. That's one point. Okay, next.
Olfactory neuroblastoma. These are uncommon malignant tumors of the upper nasal cavity affecting specialized olfactory mucosa and arising from the superior turbinate, cribriform plate, and superior one-third of the nasal septum. Their microscopic appearance, macroscopically, olfactory neuroblastoma appears as a soft, polypoidal, highly vascular mucosa-covered mass. Their microscopic appearance shows malignant cells which are uniform with small round nuclei, scanty cytoplasm, and possess finely stippled salt and pepper chromatins.
So once you pull the slide down, please. Yeah. So olfactory neuroblastoma, yes. Down. Olfactory neuroblastoma, down. This is uncommon one, as you could see here. Not very regularly seen one. The uncommon malignancy in the upper nasal cavity. So upper part of the nasal cavity, as you know, this upper part of the nasal cavity only they will be arising, and then especially specialized olfactory mucosa arising from the superior turbinate. They can be from the superior turbinate. They can be from the cribriform plate. They can be from the superior one-third of the nasal septum. So as whatever it is from the superior turbinate. This is in the olfactory mucosa and superior part of the nasal septum. Only this part they can be arising. So macroscopically, they appear as soft. They can be soft. They can be polypoidal. They can be highly vascular mucosa covered mass. Microscopically, small round nuclei. They have got small round nuclei like this, and scanty cytoplasm can be there, and salt and pepper chromatin can be there. This is very important. Lift it up, please. Salt and pepper chromatin can be there. Up. Salt and pepper chromatin can be there.
Yes. Yes, sir.
And then when you see this picture, please. Picture. So this is the appearance of that picture, as you could see, like salt and pepper appearance, and microscopically there are different things which you already discussed. Okay, next is continue.
Next is mucosal malignant melanoma. Mucosal malignant melanoma is a rare tumor that originates from melanocytes. These are of neuroectodermal derivation and migrate to ectodermally derived mucosa during embryogenesis. Common signs for mucosal malignant melanoma include the sinonasal tract and the oral cavity. Uncommon sites include the nasopharynx, larynx, and other sites non-ectodermally derived mucosa. It is more common in men, but this finding is not consistent, and the tumor affects a wide age range from 20 to 80 years.
So get a bit down, please. A bit down. So mucosal malignant melanoma, it is called as MMM, triple M. It is also a rare tumor like olfactory neuroblastoma, and like olfactory neuroblastoma, and it is derived from what is a neuroectodermal cells. So neural crest cells are neuroectodermal cells. They are of ectodermal origin during the embryogenesis. Sites are like sinonasal tract, as you see. Number one. Number two is the oral cavity. Oral cavity, also there is a possibility of this neuroectodermal carcinomas, melanomas, I'm sorry, malignant mucosal melanomas, and rarely nasopharynx, larynx, and non-ectodermal mucosa also can be participating in this. It is mucosal malignant melanoma. Especially once again, one more M, mucosal malignant melanoma, more common in men. And it can be common in a wide range that 20 to 80 years, like 20 to 80 years. Next.
The macroscopic appearance, mucosal melanoma are usually pigmented and color ranges from a light tan to black depending on the amount of melanin production. Microscopic appearance, they typically comprise epithelioid or spindle cells, plasmatoid, rhabdoid, small cell, vein cell, balloon cell, neurotropic, and desmoplastic variants are also recognized.
Yeah, as you could see, get down please. So macroscopically, when you go for macroscopic appearance, so this mucosal melanoma, it is usually, don't move it too much. Mucosal melanoma is pigmented color. As you know, melanoma is something which is related to color and ranges from tan, that is dark color, to black, depending upon the melanin. As you know, melanin is a color pigment. Microscopically, you have got epithelioid cells, spindle cells, plasmacytoid cells, rhabdoid cells, small cells, giant cells, balloon cells, neurotropic cells, desmoplastic cells. All this can be present. Get down. So all the types of different types of cells can be there. Next slide. So this is microscopic appearance. Microscopic appearance, as you could see here in this picture. So all round cells, desmoplastic cells, all the cells which we have discussed till now are all seen in this particular picture. Next.
Yes. Other neuroectodermal tumors include Ewing sarcoma, primitive neuroectodermal tumor, and melanotic neuroectodermal tumor of infancy.
So melanotic neuroectodermal tumor of infancy, primitive neuroectodermal tumor, other things like Ewing sarcoma, all these things are so neuroectodermal tumors only. These are all neuroectodermal tumors only. Neuroectodermal tumors only. Next.
Hyman's grading classification of olfactory neuroblastoma.
Hyams
Histological features. Hyams grading.
Yeah.
Histological features. There are 4 grades of olfactory neuroblastoma. In the grade 1, the architecture is lobular. In grade 2, lobular. In grade 3, it may be lobular, and grade 4 also it may be lobular. Pleomorphism. Grade 1, it's absent or slight. Grade 2, it's present. Grade 3, it is prominent. And grade 4, it is marked. Neurofibrillary matrix. It is prominent in grade 1, present in grade 2. Grade 3, it may be present. Grade 4, it's absent. Rosettes. Grade 1 and grade 2 shows Homer-Bright rosettes, which are pseudo rosettes. Grade 3 and grade 4 shows Flexner Winter-Skinner rosettes, which are true rosettes. Mitosis. Grade 1 doesn't show any mitosis. Grade 2 shows mitosis. Grade 3 it's prominent, and grade 4 there is marked mitosis. Necrosis. In grade 1 and 2 it's absent. In grade 3 necrosis is present, and grade 4 it is prominent. Gland. In grade 1 and 2 and 4, 3 and 4 they may be present. Calcification, it's variable in grade 1 and grade 2, whereas it is absent in grade 3 and grade 2.
So I'll brief it out once, just like that. Just keep it like that. Don't move the slide. So it is very important. Hyams grading. Okay. Hyams grading. You keep it in the center once. So Hyams grading for olfactory neuroblastoma. Lift it up, up, up. Olfactory neuroblastoma. So Hyams grading is olfactory neuroblastoma. Don't move it much, madam. Keep it straight. Keep it straight. Keep it in the center of the picture. As a whole, you keep it in the center. Hyams grading, the center. Yeah, that's it. Enough. Don't move it. So grade 1, 2, 3, and 4. So you should understand that 4 is worst, and 2 and 3 are in the middle, and grade 1 is the okay. When you take architecture, all the architectures may be lobular. They can be lobular or lobular. One is just like lobules, something like lobules. Next, thinking about the pleomorphism. Pleomorphism is a characteristic of cancer. It is worst. That is, marked pleomorphism is a bad thing. So it keeps on increasing. It keeps on increasing. The pleomorphism keeps on increasing in this particular grade 4. Matrix. So matrix means something which is the in between the cells. So the nucleus size is increased and all pleomorphism increased in the worst grade. Matrix is more better in the case of normal grade 1, and it is worst in the case of grade 4. And rosettes you can write Homer right, which are pseudo rosettes in 1 and 2, and flexner intestinal are true rosettes in 3 and 4. So HW, FW, FW. That you should remember as simply as that. FW is very easy and worst thing. And they are present, maybe present. So rosettes, if they are present, HW is good, FW is bad. And mitosis are marked in grade 4, which is worst, as we know that. And necrosis is prominent in grade 4. And glands, everywhere, all the things, olfactory neuroblastoma, all the things, glands may be present. That is one thing you should remember. And lift it a bit up, please, madam. And calcification, initially it is variable, but later on calcification, a better tumor calcification is absent. A better tumor calcification is absent. Next.
Hematolymphoid tumors.
Yes.
Lymphoma is the second most common primary malignancy occurring in the head and neck region. In white populations, lymphoma is more common cause of cervical lymphadenopathy than metastatic disease. Approximately 25% of all extranodal lymphomas occur in the head and neck. Thus, although in the UK, the overwhelming majority of hematolymphoid tumors, predominantly lymphomas and leukemias, are managed with specialist hemato-oncology multidisciplinary teams, head and neck surgeons are frequently involved in the initial diagnosis of lymphoma. It therefore behoves the head and neck pathologist to possess a sound working knowledge of lymphoproliferative conditions and their differential diagnosis.
Now lift it up. The slide is too low. Yeah. So hematolymphoid, you should keep it in mind. You don't move, madam. Just keep it like that. Don't move much. Hematolymphoid.
Okay.
So blood related and lymphatic related. You should keep it in mind about that one. And it is the second most common. The most important thing is second most common primary in the head and neck region, especially in white population. So lymphoma is more common. Lymphoma is more common because of cervical lymphadenopathy than metastatic disease. Is more common cause of cervical lymphadenopathy. Lymphoma leads to cervical lymphadenopathy. Whenever you have it in mind and you see it in the white population, you should think that it is a lymphoma, question mark. So 1/4, that is 25% of the extranodal lymphomas. So nodal lymphomas, extranodal lymphomas, they call it as 1/4 of the extranodal lymphomas, they occur in the head and neck region. 1/4 of the extranodal lymphomas, they occur in the head and neck region. And especially in according to the author, this is a standard textbook as we are dealing. So there is a majority of hematolymphoid tumors, predominantly the lymphomas especially, and leukemias. So these are all the hematolymphoid tumors. They are specially managed by hemato-oncology multidisciplinary teams. But head and neck surgeons should have the idea of initial diagnosis. Our work is to first diagnose the condition. So at least you should know how to recognize it. So it behoves the pathologist, especially head and neck pathologist. Sound working knowledge is needed for this lymphomas. So lymphoproliferative conditions as the differential diagnosis. So these are the hematolymphoid tumors. Hematolymphoid tumors. The hematolymphoid tumors. You keep it in mind when you are discussing. Okay. Next slide.
Okay. Lymphomas are broadly divided into Hodgkin's lymphoma and non-Hodgkin's lymphoma. Hodgkin's lymphoma is characterized by rich Sternberg cells and is subdivided into classical Hodgkin's lymphoma, incorporating nodular sclerosing mixed cellularity, lymphocyte rich and lymphocyte depleted subtypes, and nodular lymphocyte predominant Hodgkin's lymphoma. They are classified according to the site of involvement, clinical features, growth pattern, presence of fibrosis, composition of cellular background, number and or degree of ATP of the tumor cells, and frequency of Epstein-Barr virus infection.
Place the side in center, lift it up, move it up, move it up, move the slide. Yes. So as you know, this lymphomas, everybody knows that lymphomas are divided into Hodgkin's and non-Hodgkin's lymphoma. And Hodgkin lymphoma, Hodgkin HL is characterized by RS, is red Steinberg cells. So this Hodgkin's lymphoma is characterized into, classified into classical Hodgkin's lymphoma, number one, and this classical Hodgkin's lymphoma, and incorporating the nodular sclerosing variety, there is NS variety, and mixed cellularity variety, MC variety, and lymphocyte rich and lymphocyte depleted. Lymphocyte rich and lymphocyte depleted varieties. Nodular lymphocyte predominant Hodgkin's lymphoma. So as you should see, lymphocyte predominant. You should have it in mind. Lymphocyte predominant Hodgkin's lymphoma. According to site of involvement, you are going to classify it. According to clinical features, you are going to classify it. According to growth, you are going to classify it. According to fibrosis, according to composition of cellularity, according to type A, type A, according to tumor cells, according to Epstein-Barr virus. So according to Epstein-Barr virus, you will be classifying cells, atypia, fibrosis, critical features, etc., etc. According to all, you are going to classify these things. So you should know that Hodgkin's lymphoma has got Reed-Steinberg cell. Everybody knows this Reed-Steinberg cell. Classical Hodgkin's lymphoma has got nodular sclerosing, mixed cellularity, lymphocyte rich, lymphocyte predominant, lymphocyte depleted, as you know. Next.
Roughly 85% of the non-Hodgkin lymphomas are B-cell lymphomas, which include follicular lymphoma, marginal zone lymphoma, and marked lymphoma. The latter often extranodal, involving the mucosa-associated lymphoid tissue of Waldeye's ring, including the ocular adnexa and thyroid gland. Non-Hodgkin lymphoma of the thyroid gland is more common than undifferentiated anaplastic carcinoma of the thyroid gland. Diffuse large B-cell lymphoma is the most common aggressive non-Hodgkin lymphoma.
So among these non-Hodgkins, almost 85% are B-cell. They include the follicular lymphoma, they include the marginal zone lymphoma, and they include the maltomas, malt lymphomas. So this is all about the B-cell. Non-Hodgkins means Hodgkins is more common and Reed-Steinberg cell. Now non-Hodgkins we are discussing, that is B-cell. And it is extranodal, whatever is the maltoma, mucosa associated lymphoid tissue of Waldeye's ring. So you have got that malt. This malt is associated with Waldeye's ring. This malt is associated with Waldeye's ring. Should we keep it in mind? Keeping it in mind. And ocular adnexa also maltoma common. And the third one is thyroid gland. Thyroid gland, especially very important. Non-Hodgkin lymphoma of the thyroid gland is more common than anaplastic carcinoma. Anaplastic is less common, non-Hodgkin lymphoma is more common. So most aggressive and most worse is diffuse large B cell lymphoma. So DLBCL, the most common aggressive. So DLBCL is the most common aggressive tumor among this non-Hodgkin's lymphoma. So you should have it in mind about the violet ring, mucus-associated lymphoid tumors, and B cell lymphomas, etc., etc. Next.
Mantle cell lymphoma and Burkitt's lymphoma are aggressive non-Hodgkin lymphomas sometimes in the head and neck region. Cutaneous T-cell non-Hodgkin lymphoma, example mycosis fungoid, may be indolent. Peripheral T-cell non-Hodgkin lymphomas, however, may behave more aggressive. Extranodal NK or T-cell lymphoma is strongly associated with Epstein-Barr virus infection and shows a predilection for the upper aerodigestive tract, prototypically the nasal cavity.
So mantle cell lymphoma, once again, mantle cell lymphoma is one important point, and also your Burkitt's lymphoma. These are also aggressive non-Hodgkin lymphoma in the head and neck. And as you've seen that like maltomas, etc., etc. Burkitt's and mantle cell also involved in this. And cutaneous T cell lymphomas, they are very important. That is MF, that is mycosis fungoides. They can be indolent. Next is peripheral T cell non-Hodgkin lymphoma is more aggressive. So peripheral T cell is more aggressive, and extranodal or NKT cell lymphoma is strongly associated with Epstein-Barr virus. NKT, extranodal NKT is associated with Epstein-Barr virus, very important. Extranodal NKT is associated with Epstein-Barr virus, and it has got a upper aerodigestive tract, as you know, and especially nasal cavity. Extranodal NKT is very important, especially the nose. Extranodal NKT, especially the nose. Next.
Its angiocentric and angiodestructive nature may stimulate vaginal granulomatosis and other midline facial necrotizing conditions, so-called idiopathic midline destructive disease in the older literature. Plasma cell neoplasm, more commonly plasma cell myeloma and extramedullary plasmacytoma, are occasionally encountered in the head and neck region.
So angiocentric, that is related to blood vessels, and it is blood vessel destructive, angiodestructive. You should keep it in mind about this lethal midline granuloma. And it is similar to vaginal granulomatosis, that is midline destructive lesions, similar to this vaginal granulomatosis, similar to that. And facial necrotizing conditions, they become dark and charred like a gangrene. So it was previously called as idiopathic midline destructive disease in the older literature. Idiopathic midline destructive disease in the older literature. And otherwise, plasma cell neoplasms and like plasma cell myeloma, extramedullary plasmacytoma, occasionally encountered in the head and neck region. Okay, occasionally encountered in the head and neck region. Next.
Mesenchymal tumors. Apart from lymphomas, mesenchymal tumors are uncommon malignancies of the head and neck region. Malignant mesenchymal tumors, that is sarcomas, include fibrosarcoma, malignant fibrous histiocytoma, leiomyosarcoma, rhabdomyosarcoma, liposarcoma, angiosarcoma, Kaposi sarcoma, malignant peripheral nerve sheath tumor, synovial sarcoma, chondrosarcoma, mesenchymal chondrosarcoma, osteosarcoma, chondroma.
Sarcoma. Okay. So lymphomas are over till now, and we have got the mesenchymal tumors, especially mesenchymal. You should have it in mind. They are very rare malignancy, uncommon malignancies. What are they including is that fibrosarcoma. Next is malignant fibrous histiocytoma. Next is leiomyosarcoma and rhabdomyosarcoma, liposarcoma, angiosarcoma, Kaposi sarcoma, malignant peripheral nerve sheath tumor. This is all related to sarcoma, and synovial sarcoma, and chondrosarcoma and mesenchymal chondrosarcoma and osteosarcoma and chordoma. All these things are related to sarcomas. That is nothing but your mesenchyme related tumors. Keep it in mind. Next.
Secondary tumors. Tumors from other regions can metastasize in the head and neck region. The site paranasal sinuses. The primary tumor may be kidney, lung, breast, thyroid, prostate. Nasopharynx, very rare. Case reports or small case series have been reported. The primary tumor may be from malignant melanoma, kidney, lung, thyroid, colon, breast, cervix.
So all these things are related to that. You should keep it in mind about the secondary tumors, that is lung, breast, especially lung, liver and breast is very important. You keep it as mind as LLB. Next.
Hypopharynx and larynx. Melanoma, kidney, breast, lung, prostate, colon, and stomach cancers may metastasize to hypopharynx and larynx. Oral cavity and oropharynx, breast, kidney, lung, prostate, thyroid, colon may metastasize.
All this can go to that actually. Next.
Salivary gland. More common, accounting for 5% of salivary gland malignancies, predominantly occur in the parotid gland. 80% of the parotid gland secondary tumors are from other primary head and neck tumors. 85% of the submandibular gland secondary tumors are from distant sites, including lung, kidney, and breast.
Okay, as you see here, 80% of the parotid secondary tumors are from other head and neck neoplasms, and 85% of submandibular tumors are from distant sites. So from parotid, for parotid, other head and neck regions, if you take this as the head and neck, parotid, most of the times from other head and neck regions they come. Whereas in submandibular region, but this is a submandibular region, if you think, so distant sites like lung, kidney, and breast, these are going to lead to submandibular gland tumors. Next.
Ear and temporal bone. Very uncommon, but post-mortem studies suggest may be more common, especially in patients with disseminated malignant disease. They can be from breast, lung, head and neck, prostate, melanoma, thyroid, and kidney.
Okay, especially temporal bone are very uncommon, and they say from once again lung, liver, bone, etc., etc. You can talk like that. Next.
That's it.
Done. Only this much there for you. Yeah, okay. Thank you very much for presentation. Thank you very much. Thank you very much for the presentation.